Welcome, everyone, to Residency Hot Topics. I am so excited to welcome a true world renowned specialist in the area of Achilles tendinopathy and all things tendon, and that is Dr. Karin Silbernagel. Karin, the floor is yours. Thank you again for joining us.
Thank you. Thank you so much for having me. And can you hear me okay? Perfect. So thank you everyone for coming and signing up and things too. I'm really excited to be here to talk about one of my favorite topics. So we're going to talk about Achilles tendinopathy and try to get down a little bit to the nitty gritty and hopefully have some time for questions and things too. So I'm a professor at University of Delaware, and there I run my research group. It's a University of Delaware Tendon Research Group. I also teach in the doctor physical therapy program, and we also have a big clinic, so I see a lot of patients clinically there too. So in order to kind of get going, and if you've done research as long as I have, so I've been a PT for 36 years, and then I've done research for probably 25 years on tendon injury, you kind of want to start reflecting on where you're starting. And I think it's important to kind of remember where we were with tendon. So when we're talking about the historical perspective, right? A lot of times the tendon injuries were all these chronic tendon injuries, right? So when I started in PT school, nobody really talked about tendons. It was just the rope that attached the muscle to the bone. But then when I started in the clinic, everybody had tendonitis, right? So we knew then itis was inflammation, so was inflammation in the tendon. But then as we kind of move forward and research expanded and things too, it was kind of found that there was no really sign of acute inflammation at the site of injury. So this kind of made us like, when I learned like tendonitis, you were thinking ice, rest, anti-inflammatory. But if it's not an acute inflammation, you started interesting. So how does then tendon get injured and how do they recover? So we really saw this huge paradigm shift in treatment, right? We then decided to, if it was not tendonitis, maybe we didn't have to do all this rest and ice and anti-inflammatories. And then we started to call it tendinopathy. And that's when we really started to thinking about that tendon needs loading and exercise actually to stay healthy and to recover from injury. And we started to thinking about that maybe it was okay to have some pain. And I did a lot of research in my PhD looking at the pain and pain monitoring model. It's okay to exercise with pain. And we see that with exercise, we actually do have a really good effect on the tendon. However, it takes time to recover. And really, what we're working on now is to determine the ideal loading conditions and for whom. And that's really where we're going to be. So one of the things I want to emphasize too, that if you are interested in tendon and tendinopathy, we are a large international consensus group. We've done studies really kind of to understand to call it tendinopathy. So we try to avoid the word tendinitis nowadays. It's still the kind of, people say that anyway, but it's kind of to make sure that we don't signify that this is an inflammatory condition. So we call it tendinopathy, and the kind of preferred term for persistent tendon pain, loss of function, and related to mechanical loading. And when we're looking at terms, we have like Achilles tendinopathy, patella tendinopathy, peroneal tendinopathy, medial lateral elbow tendinopathy. For shoulder, we don't call it, maybe some call it rotator cuff tendinopathy or more like shoulder pain because it's hard to sometimes know if it's specifically from the tendon. And if you're interested then too, we have really try to figure out what are the core outcome domains and what are patient characteristics that really matter. So I think this has been, for me, an exciting time to show that tendon injury actually matters in tendinopathy, and we're trying to make sure that everybody on the same page so that we can expand our research and our knowledge. But that might be more than you wanted to know. But really, one of the amazing things, especially for a physical therapist, is that exercise as treatment has the highest level of evidence for tendon injury, tendinopathies, these overuse injuries. And that continue even with all the orthobiologics, with all the other things that comes up. Either they have to have exercise with it, or exercise has been shown to be better evidence and in both the short term and the long term. The problem, though, with exercise is that response is varied and not everyone recovers the way we want it to. And it takes a long time. I mean, I usually tell my patients it takes 6 to 12 months to be kind of fully recovered, and you need to work on it. And we've also seen recurrence rates are high, and we've seen especially in when you see in sports that the shorter time off, the shorter rehabilitation, the higher the reoccurrence rate. And this has been for my research lately too. Like, does one size fit all? Where are we, and how can we get better? And this is something that I usually put out now too, because I think back in the late 1990s, when we went from no exercise to exercise, we really had this steep increase in improvement of outcomes. So going from no exercise to exercise was really effective. But now I think we're really good at exercising, and now we get reading, closer to the saturation point. Like, how do we go to the next step? And I think this is when we really start thinking about, does one size fit all? How do we adjust exercise for the person? What are the precision rehabilitation or individualized treatment of the person in front of you? So kind of taking a step back a little bit for Achilles tendinopathy. So we're going to focus on Achilles tendinopathy. Our research, some of it mostly we do with lower extremity, but we see even in others are done in shoulder and other area. A lot of it can kind of be extrapolated to the tendon broadly, but sometimes we need to be more specific of which tendon we're talking about. So Achilles tendinopathy is the most common in the lower extremity and affect all ages from athletes to sedentary. And I think that's important. We thought that there was mainly a athlete injury, a runner injury, but it's not. We can see a lot in sedentary as well. We see an increase in incidence both in older and adolescents and in those with metabolic disorders. So maybe it's not only an increased incidence, but we're starting to realize it's more broader in a lot of various patients that you have. And we've seen that wait and see is not an effective treatment. And some of the newer studies out of the Netherlands too really shows that it affects work productivity and has a negative impact on quality of life. And they have described as healthcare costs similar to knee osteoarthritis. So this is kind of a problem. And I think sometimes we have not treated it as such. People just stop loading instead of stop walking, which we also know is a negative effect of general health, right? So that's why I think this is really, really important. And to kind of put it in perspective, this is kind of a slide with a lot of various things too, but I think it's important to realize that when you're looking at tendinopathy, we have symptom changes, we have functional deficits, and we have structure. We see alterations in tendon structure. This kind of graph that you can see there with the x-axis being time over months and the y-axis being severity really tries to represent like the overuse type of injury. And what it really means is that people can start overloading the tendon and not having enough recovery. You might not notice structural changes or symptom changes or function changes right away, but sometimes it gets to a tipping point. And when the patient comes to you, they're often described they started walking more, they changed a job, or they started running. And they might have been doing that for maybe 6 to 12 weeks, but it's one last run or one walk when they really, now it happened to them. But it usually is this process ahead. And these ultrasound images is just to show that we can see changes in the tendon structure. And when we see tendinopathy in the tendon is really good at, absorbing and rebounding to help us save energy with running and jumping activity. So the tendon is like a good rubber band, right? You stretch it up and it kind of recoils and it makes you more efficient. You don't have to use as much energy maybe for running in every step. So when we see the tendinopathy, the changes in structure that could happen before symptom changes make this tendon not as good at recoiling. It's more like a basketball with good air. You don't need a lot of energy to bounce it up and down. But if you take some of the air out, changing this the kind of the tension of the basketball, you can still bounce at the same height, but you need to use a lot more energy. And that's kind of what happens, what we see with the tendon, with tendinopathy, it becomes more compliant. And this can kind of come together with either pain or not may not be present to kind of look at. And I want you to illustrate this from one of my runners who has tendinopathy on one side and not the other side. And you can see when he's jumping on the left side, it's a lot harder to kind of bounce up and down. He uses the shoulders versus on the other side, it can really bounce really well. And this is kind of to illustrate these kind of structural changes along with pain, along with the function that we can look at. So the next step too, we're not going to spend a lot of time, but we just published a study of this consensus group two in BGSM, and really also looking at diagnosis. So one of the things I want to say to clinicians is just because somebody comes in with Achilles tendinopathy, you're not sure if that's it. You do your due diligence, right? Where is the pain? Pain on palpation? Do they have pain with loading, to make sure that differential diagnoses are not being missed? And especially nowadays, we also talk about people with systemic diseases or rheumatoid arthritis that can have more of the enthesis problems. I think this is really key. You know, we get so excited about new things and learning new things that sometimes we forget the basics. Okay, so the thing that we are really talking about then too, and I was trying to allude to, is that we try to emphasize tendon health. We want healthy tendons. And to have tendon healthies, there are several domains that kind of fits into the tendon health and injury. And one is function, right? You want to look at this jumping, you want to have good function, good heel rise function. You want to minimize symptoms, right? We can measure symptoms with pain, pain with loading, or also quality of life, psychological factors matters, or fear of movement. And structure is more the tendon structure that we measure usually with ultrasound imaging. And I think those are all related to tendon injury and tendon health, but we need to realize a lot of the clinical trials are just focused on improving symptoms. And symptoms can be relieved by rest, but reoccur with loading. So we got to be careful to only assume that a treatment is effective just because we relieve the pain, right? It's one of the things that I say all the time, like somebody with Achilles tendinopathy, I can get them pain-free, you know, within a minute. You sit down and don't load it, you don't have pain. Some might have pain at rest, but most of them don't, right? It's pain with loading. So you need to kind of thinking about, like, even though now maybe you have decreased pain, but you also want to make sure that they can return to their activity, they can return to walking and not, you know, continue to have increases in pain. So this has kind of been our model for tendon health to understanding it. And it's, you know, it starts as a model and hypothesis that you have, but we actually looked at it within our data and we can see that we have 5 different domains. We call them a little bit different in this paper, but they're all uncorrelated, meaning that somebody can have more pain with hopping, but their function can be good, or somebody can have a lot of fear or changes in structure, but maybe not have a lot of symptoms. So that's when we always, like in the clinical practice, right? You want to evaluate, you don't determine the severity of any injury just by one measurement, right? You want a variety of measurement to understand the severity. And this is going to be really important for tenderness as well. And where our research have gone in the last, I would say, strongly in the last 4 or 5 years too, is really to understand some more of the personal factors, right? We've done one study with genetics with a Swiss group too. So there are some genetic factors predisposing you to having tendinopathy. Age, we can see that certain age, you know, 35 to 45 is the highest for tendinopathy, but now we also see it in adolescents and older. We see a lot with metabolic risk factors. So, you know, obesity, but prediabetes, high cholesterol are problems relating to increased risk of tendinopathy. And the other thing that we're working on now too is also looking at hormonal state and looking at hormone fluctuation in females and female athletes to see how that relates to the changes. So I think there is a lot of things to understand here and kind of thinking about when you see the patient in front of you that could affect how they are responding to your treatment. So really moving forward with that, we did some really exciting stuff. So Sean Hanlon was a PhD student of mine, and he's now in academia in California, Fullerton in the athletic training program. And Ryan Polig is my biostatistician. So when Sean was a PhD student, we had all this data and we really started to wanting to understand, are there subgroups of people, right? Is it that this one size fits all might not fit all our patients? And are there subgroups that we just don't know, we can't see? And we used our data to really looking at that to determine, do we find subgroups and do they recover differently over time? And this is important to understand. We used all our measurements and kind of put into it. The method is you don't determine the subgroups ahead of time. Like you're making the data to see if the data can find, yeah, these are different groups that have similar kind of symptom severity across the domains. So for this study, and we published both two kind of, but this one is also looking at the recovery. So here we had 114 participants with mid-portion Achilles tendinopathy. And really what we found was four subgroups, which I think from my clinical experience is like, oh yeah, I've seen these patients. And to kind of explain a little bit to you, for you too, I hope you can see my arrow here too, but these circles are color coded for the various domains that we're measuring. Like green is function, drop, counter, movement, jump, heel, rise, work. Yellow is more of personal factor and Faust quality of life. Blue is pain and visa score, which is a questionnaire. The red here is Tampa scale of kinesiophobia, so more fear of movement. And the purple is were various factors to look at the tendon, how the tendon looks in cross-sectional area. And the dotted line that you can see in the circle, that's the average of all the participants. And then the solid line in each group is kind of describes that subgroup. And the further out you are, the more deficits you have in each measurement. And the closer to the center, the less deficit you have in that. So these are C-scores. So this is kind of normalized to the group. And I think what's interested in, and that we had one group that we call the activity dominant. It's a little bit younger, around 37, 68% identify as runners. And they do not have a lot of functional deficits. They have symptoms, but they don't have a lot of fear of movement. The tendon structure is not that bad either, right? But they do have the symptoms that it is. And we kind of look at those, maybe those that are high level runners that are more overloaders, maybe need to modify load versus having to worry about that have deficits in function. The second group, like the function dominant, right, is very similar to the first one, but they have a little more problems or changes in their function. They're a bit older, but still 68% runners, right? So they have a little more functional deficits. And then we have these other two groups, psychosocial dominant, which is a group predominantly females. And they had a lot of changes or deficits in their function, but they also had the highest fear of movement, so highest score on Tampa scale of kinesiophobia, and a lot of symptoms. But their tendon structure didn't have a lot of changes in the tendon structure. And then we had the last group we called more older, mainly male, obese, overweight male, and they had really horrible looking tendons. The structure was very much affected of the tendon and their function. But they didn't have that bad of a symptoms, and they did not have high fear of movement. So these how you can start looking at these different kind of structures, subgroups, that you might understand, like, do they actually need different kinds of treatments? And then we had, before we looked at the subgroups, they were all part of a study where we used our exercise program. So we used an exercise program along, and we're going to talk about that in a little bit, using pain monitoring model, education, and progressive heel rise exercise and progressive tendon loading. And when we looked at that after 6 months is where this main data is, that we saw that they all improved, but there were some differences, right? So the activity and function dominant achieved functional recovery despite having some persisting symptoms at 6 months. The psychosocial dominant, that one that had high fear of movement, reported the greatest impairment in symptoms and foot and ankle related quality of life at all time points. So they had more of those. They continued to improve similarly, but had more of impairments in those areas. And the structure dominant was the one that was worse tendon structure, experienced delayed improvement in symptoms, and was the only group that did not achieve structural recovery. So you can see that no subgroup met the criteria for complete recovery in all domains. And this is around 6 months, which I would expect, and we continue to see improvement up to a year as well. But what I also want to emphasize too, that everybody was really satisfied with the exercise treatment. So just because they didn't recover fully doesn't mean that they did not improve. And the global rating of change also shows that they were really happy with the exercise program, but they recover a little bit different. So that's important clinically, right? To know that maybe somebody would have a structural dominant changes, a lot of changes, might take a little bit longer. And I think if people have the right expectations, then it's a lot easier for us to provide them support and have them continue exercise as well. And just to kind of looking at another subgrouping that we did, because a lot of times we're thinking about Achilles tendinopathy in runners, and here we had 177 individuals, and 81 of those were identified as runners. Well, they actually self-identify as runners or non-runners, and 96 was non-runners. And here we see that runners had less symptoms. They had better function, less structural deficit, and lower BMI. So again, this might be the person comes in, they have a lot of overuse more, they have started running, they haven't had the recovery. So those are the ones a lot of times it's like, okay, here is more important that we're talking about load control. We're thinking about you shouldn't run every day, and we kind of modify those things, but we're not as concerned about building up the function, but we're still going to give exercise to load the tendon because that is what's going to recover the tendon. And I just have a few more thinking about the various subgroups. A lot of people are interested in the fear of movement and kinesiophobia. So we've looked at this in two different cohorts. We looked at it in one cohort that we didn't provide the treatment. There was a top one, and here we provided the treatment in the bottom graphs. And to summarize that, what we see, we divided them into high kinesiophobia, so irrational fear of movement due to pain mostly, medium and low kinesiophobia. And this group did not provide treatment, but they got information at baseline, and we can see what happened over time was more so that the kinesiophobia decreased in the high and the medium group and kind of came together at 6 months. And when we're looking at it after 8 weeks of rehabilitation with our exercise program, the high kinesiophobia group, which is red down here, had worse symptoms. They had worse heel rise work, obviously the highest score on the TSK. But with 8 weeks, we can see that they're all recovering similarly. So I think it's important to understand a lot of people come in with fear of having a rupture. And that is maybe that main fear that they have. But with education, a lot of times we can say you need to exercise, you need to load the tendon to tendon to get stronger. And we also have data to show that people with Achilles tendon ruptures are not the ones that have had symptoms, and people that have symptoms are generally not the ones that go on to rupture. So that is also a lot of things for people to understand, that loading the tendon is critical to making it stronger, even if you have pain. And a couple more things in that too. The other thing that we get a lot of questions on is the stage of tendinopathy. The continuum model by Jill Cook has been often discussed in Karm Khan about, acute on chronic injury and things too. And people talk a lot about it from how long people have had symptoms. But we've done in 2 different studies really looking at this stage of tendinopathy with people with less than 3 months or 3 to 6 months of symptoms, 6 to 12 months or over 12 months. And when we're looking at their baseline symptoms, function, tendon structure, or psychosocial factors, we see no difference at baseline, and we see no difference in how they recover over time. So if you're thinking about the stage for tendinopathy, it's probably not like how long they have symptoms, and probably because, as we talked about earlier, they might kind of have changes in structure and other variables before they might have noticed the symptoms. And the other study we published recently too was to look at, central sensitization inventory, thinking about the people who had pain for a long time. There might be more of those with central sensitization, but duration of symptoms did not relate to central sensitization. And this is probably mostly relevant for lower extremity tendinopathy. We do see some differences when you're looking at tendinopathy in the upper extremity. And the last one to look at too is, again, kind of emphasizing the metabolic risk factors. So this is metabolic risk factors in general, people thinking about people that have high blood pressure, high BMI, that might have prediabetes or high cholesterol. And basically what we see is that they have worse symptoms with loading. They have worse kind of function. And they also have smaller tendon relative to their body mass, which can kind of explain why some of them with metabolic risks start to develop tendinopathy, even though we don't consider them as overloaders, just the body weight might be overloading. Okay, that was a lot of things to kind of thinking about, but really what you want to do is, I guess for me, that summary is more to think about like, who do I have in front of me, and thinking about this one size might not fit all, and thinking about how do I then design my exercise rehabilitation for this person, and what are the expectations, and where do they want to go. So exercise rehabilitation still have the highest level of evidence for treatment for all of those individuals. And that's what I think is really exciting and must try to show you as well. But what is the exercise and how do we do this? Like what do I do with the patient in front of me? And this is more to kind of share some of the data, but what we've seen, and there's a lot more data or information than is right here, but tendon cells respond to mechanical stimuli in form of strain. So tendon wants kind of a strain, meaning you want to pull the tendon apart, and the amount of strain or stretching that you're doing on the tendon relates to amount of load you're pulling through, and that relates to the recovery of the tendon. And basically, some of the studies have shown that then with higher loads, when you have more strain of the tendon or more stretching that tendon out, that's when you have that the tendon gets more stiffer and greater cross-sectional area, so it responds positively to the load. Versus doing maybe a lot of repetitions and don't have a lot of strain, right? So that kind of comes from, and that's where people are coming from, like heavy, slow resistance and those things that the tendon needs this kind of load to have change. And we also see that if you don't load a tendon or a tendon cells, they actually get worse, right? So complete offloading of the tendon is the same as almost like overloading. You see structural changes in the tendon. We did publish also in 2015, and I don't think that debate is much that big anymore, but if you're interested, you can look it up too. But I think the key is when you talk about eccentric or concentric exercise is that the tendon is in series with the muscle. So the tendon doesn't really know if you're contracting the muscle concentrically or eccentrically, but it does know how much load goes through that tendon as part as in strain, right? So the loading is more important, but probably not necessarily if you're doing eccentric or concentric, rather thinking about how you're loading that tendon and what part of the range. The other thing that's been a lot of discussion too, and I get it all the time when I consult with professional teams and things too, talk about the isometric loading. But again, the tendon just knows how much load, it basically knows how much you strain it for how long you're loading it for. And isometric loading has not been in certain areas been shown to have better pain relief than other exercise as well, right? So thinking about it from your perspective, you want to have load through the tendon. If somebody, for example, in the Achilles tendon also have pain in the ankle joint, so they have pain when you're doing ankle movement, you might want to focus on isometric loads and longer hold to get load through that tendon, right? If somebody that really you want to work on dynamic loading or standing, you can just do the heel rises early on and kind of warm up. So you can kind of pick your exercise just thinking about that you want to get load through that tendon. And the last thing with exercise too, like I'm talking a lot about exercise to promote tendon healing, but exercise can also reduce symptoms, right? So it might not just be isometrics, but just actually for the ankle, just pump the ankle up and down. You're going to get circulation both in the tendon and the ankle, and that warm up is going to feel better, right? Then if somebody has deficits, you might really want to thinking about how do you strengthen the muscle, right? Versus just loading the tendon, that can be differences as well. And then you have the recovery or neuromuscular function. And eventually you want to be able to be sport specific or activity specific. So when we're talking about this, then what is the goal of treatment? And I alluded to this a little bit earlier on too, right? But I think from my perspective and my research too is again, and you need to talk to your patient about that, they come in because of pain. But I also tell them, I can get your pain down right away. Just don't load it, right? And doctors do this a lot. They give them a boot and now they don't have pain, but that doesn't help the tendon necessarily. The tendon needs some kind of load to improve. Sometimes it could be good maybe with a boot for a little bit just to calm things down, but in general, That's absolutely not needed because you want exercise and load through the tendon. But so really the goal is to get their activity level to be where they're at and then eventually have the pain go down with that activity level. So I think that's really important to think of. And when you're thinking about the clinical consideration, the biggest issue we see with tendon is this kind of yo-yo effect, right? Somebody's loading it a lot and I'm going to train and then, ooh, boom, now I have a lot of pain. So I'm not doing anything. And now I'm going to load it again. And oh, and now I hurt and now I'm going to rest. So instead of having a positive trajectory where the loading giving them benefit, it gets to be the complete opposite with overloading, underloading, overloading, underloading, and you get a decreased tissue tolerance, right? So this is kind of where you really want to avoid. And you do see this clinically a lot. People's like, oh, I was running and then I took 3 weeks off and then I started running again and now I have the pain, right? So kind of I explained this, that this is what is the biggest problem. The other thing too, when you start out with the rehabilitation is that they are really sensitive in the beginning, right? You want to make sure that you don't underload, you don't want to overload. And that kind of balance in early on, it's kind of hard to find, right? So that's why you really want to fine tune the exercises and get going in early on. And in order to get to a discussion with the patients, we use the pain monitoring model. For since my research in the late 1990s. My PhD advisor used it for patellofemoral pain really effectively. And really what it is meant for is for you and the patient to kind of make sure that we are loading the tendon, which is critical, but we also want to find that balance of not overloading it by giving it proper loading. So we use a scale 0 to 10, 0 being no pain, 10 being the worst pain, and we have then the green, yellow, and red zone, right? So 0 to 2 is what we call a safe, acceptable zone, and people can be fairly active. And then 2 to 5 is acceptable. And then over a 5, we're concerned, and that's when we want to change the activity level or what they're doing. And I think the key is for when you're using the pain monitoring model too, is that you really, especially for tendon, you want to judge it for the next morning, right? Because sometimes you can do something while you're doing it, it feels good, but it's not until the next day how you're feeling. And we actually assess morning pain, lowest and highest pain for every day in our training diaries to kind of understand the fluctuations so we can follow their progress over time. Because when we use this, we always use a training diary. So I always document where it is because it's hard with tendinopathy. You're saying 6 months to a year. We want to find this, fine tune their loading. And it's hard to do that just when they're in the clinic, right? So they do daily exercises and then they have the training diary at home where they document what exercises they did, other physical activity, and the pain level. So every time they come in, I usually look at them in like 2 or 3 weeks in a row to kind of put it down and look at it. Then you can see, for example, somebody comes into you every Monday and they have a lot of pain. But Friday, you see them maybe Monday, Wednesday, Fridays, or Monday, Friday, they're doing great. And then Monday again, they have. If you have the training diary, it could be as simple as somebody cutting the lawn every Sunday, right? To starting to understand what they do and they don't have the recovery. And it helps the patients too. And I'm realizing it's going to be really hard to look at our exercise program, but this has been published. I'm more than happy to share it, and we're going to talk a little bit. But we have the program that I've used since the late 1990s, and sometimes now it's called the Silbernagel protocol, but it's kind of the progressive Achilles tendon loading strengthening program using the pain monitoring model and the training diary. And we try to do it as part of 4 phases. And we've always tried to have like a patient status, the goal, and what we're trying to progress for with the exercises. And this is not anything, no rocket science, but it's nice standard to have, right? So the first phase when somebody comes in is like, those will be the one with pain and difficulty with all activities, difficulty performing 10 single leg heel rises. So when you're thinking about on the subgroups, then for example, the activity dominant that's running, they might not even have to start in the symptom management stage because they might be a little bit better. But starting to thinking about what they are, and for a lot of them with a lot of pain, the goal is just to start the exercise. They want to understand the nature of the injury, how to use the pain monitoring model, and we progress to 100% of body weight, right? We want to progress. If they can't do a single leg heel rise, we can do bilateral, we can progress to one, we can do seated with weights. And we want to do a slow motion, kind of getting control and getting a lot of the neuromuscular control. The recovery phase then is more people have pain with exercise, but less than 2 to 3 with ADLs. They have morning stiffness and pain with exercise. And that might be the, I see I said that twice there, but this is more maybe the activity dominant and function dominant when they come in. Some of them are maybe coming in more around this phase, right? So this is when you start strengthening a tendon and the muscle, and you can progress the load and speed. But here we work a lot as the recovery. We're looking at recovery days between. We do exercises every day, but maybe not running. We do running maybe every 4 days if that's what they want to do. And I'm going to talk about that a little bit later too. So a lot of times what we do bilateral heel rises as warm up. Then we do single leg heel rises. We can add eccentric to that too. If they're tired to single leg, they can do only the eccentric phase. We do a lot of seated heel rises. And if they go to the gym 3 days a week, they can do more of the heavier there and do the lighter at home. So I think, yeah, not all patients start at level 1. And then people get into the rebuilding phase. It's more when they doing well with previous level and desire to progress to heavier activities, right? So you can start with more standing in the Smith machine. Kettlebells is my new favorite for calves, especially seated calf raises, because you can really fit the kettlebell easily on the knee, and you can get heavy weight through there, like 55 to 70 pounds kettlebells to on the knee. And now you're really starting the heavier exercises, and you're starting to kind of progress to see if they can tolerate running and jumping and progress to plyometrics. And then the last stage is more of the return to sports. And usually this stage for us is when they have minimal symptoms. So they're in that green phase, right? In the pain monitoring model, where ADLs has no symptoms and things too. So this is when we return first to team before, and the return to activity before they completely return to sports. And this is usually, and they can get to this maybe in 3 months, 4 months, but a lot of times we kind of progress the exercises and keep this maintenance program at least for up to a year. So clinically, I think it's important too, when you're thinking about this kind of ladder, right, is that I see sometimes in my older sedentary people that somebody has learned of all these phases, and they're trying to push them into the rebuilding and return to sports phase, and they get loaded too heavy, right? So thinking about some people might leave, right? Leave at different stages. So what is failed treatment, and when is the treatment failed? Like talking about those things. Some people are just happy in the recovery phase. They can do the exercises. You don't necessarily have to make every person start jumping in the return to sports. To kind of thinking about where they're at and what they need to do, right? And especially tendons takes time to recover, right? So not necessarily pushing into the next phase if the patient is doing well. And what we see clinically too, sometimes you want to kind of get people to level out on one kind of stage before they can progress to the next one. And people are going to have setbacks. I tell everybody that right away, and that's perfectly normal, and it's important to understand. If you really want to understand more of the exercise and things too, we have published to really understand the progression of loading, right? Because we all say we're going to progress the loading, but how does the various activities? And this article we have, I took out some of the exercises we did here too, but I think it helps to understand, like here, walking is usually 5 times body weight here, versus running can be more up to 5 times body weight, right? Single leg hopping is usually the heaviest load that we have. Here we have up to 7 to 8, and sometimes described with the speed of running or hopping that it can be even higher, right? Single leg heel rise, one-legged for tendon loading, is down here by walking. So thinking about the tendon loading that you're having in the various exercises, how to progress, will really help you with the progression. So now we talked about the various progressions, and you might have heard a lot of things out there. And there are, heavy slow resistance training, Alfredson's protocol, it's our protocol, a lot of various things looking at the various exercise program. And what's been really interesting to see is that when you compare, for example, heavy slow resistance training with corticosteroid and eccentric decline squat in the knee, you didn't really see much of a difference. You compared moderate to heavy load, in patella tendon, they didn't really see big of a difference, and they're doing the same study now for Achilles tendinopathy. You compare the ultrasound's eccentric protocol with our protocol, and not really any difference, right? Various loading protocols. So it seems to be that we really try to find the perfect load, but again, just loading and finding for your individual might be the key as well, right? To kind of listening to your patient, understanding who they are, and progress their load. So for me, one of the most important factors is to start out with loading it and not get stuck with too many things, right? And definitely not give them AFOs and things too, which I've actually had a patient that came into our study with bilateral AFOs and couldn't walk her dog because the doctor kept on giving her immobilization. They just made her worse. But instead, we started with exercise program, and then she did fine in the next 5 months. And then I got this video from somebody and asked, is this your patient? And I'm like, yeah, probably, right? So there's also this, like the daily loading of the tendon is important to get your daily medication. And sometimes we make things too complicated. And then if we make it too complicated, the patient is not going to do it. It's not going to help them either, right? So for a lot of people, it just is a matter of starting to load and moving it forward. And that goes with home exercises. I see my patients sometimes once a week, twice a week, maybe for the first couple of weeks to find that balance. But then it's on them. And I think that's important to give it to them too. So the home exercises is critical, and they come with me to the training diary. And then we might work in the clinic if there are other things that we really need to work on, considering joint mobilization or other things, right? But home exercises is really important. And I'm just putting this because this was a patient gave me this too. This is tires in Sweden. So in Sweden, we have winter tires and summer tires, depending on the weather. So this is his tires. He built this chair with the feet underneath so he can do his seated heel rises. And this is another patient here in the US. We had the incline. We want them to start on an incline into the rehabilitation, get a longer range of motion. So he had a shelf in his cubicle with some papers. So my point is that this is what you want your patients to do. Like, you want them to be consistent in doing it over time. It's not good enough to say, sure, I did my home exercises. A tendon needs this consistency in order to do well. And you sometimes can't achieve all of that in PT. It has to be the buy-in. And that's what I think the training diary and pain monitoring model really, really helps. The stretching is another question too, and I rarely give stretching, but if somebody has limitations in the range of motion, then I think they should do stretching and maybe joint mobilization. But what I want to emphasize is that patients with Achilles tendinopathy has morning stiffness, but the tendon is actually more compliant. So doing stretching for a symptom sensation is not the right thing to do. So if you're going to do stretching, it should be because they're tight, or if they do a lot of heel rises and cramp up, stretching is good. But in general, the tendon is more compliant despite the sensation of stiffness. So the last part here we're going to go into is just to start thinking about, this is our current research too, and I think is really interesting too, right? When we're talking about this heavy versus moderate, and we have, preclinical model, animal studies looking at the loading, what's important, and how much loading. And we just finished one animal study that I think is really, really interesting, trying to look at this overload model. And what we saw was, initially, this overload model showed that the tendon actually adapted in a good way. So first the tendon loads and it adapts by getting stronger and better. But then with the continued overload, after about 8 weeks, we started to see more of a tendinopathy, right? So loading is beneficial, but it's probably overloading or loading along with the recovery. It's going to be really important. And then knowing how your exercises affects the tendon. So one of the things that I have thought about a lot too is that we see, this is a study from Denmark that actually injected into around the tendon and caused pain. So when you're causing pain around the tendon, they can see that you get inhibition, just like we see in the knee, right? When you see the inhibition after swelling in the knee or those kind of things too. And this is the same thing. They saw reduced EMG and agonistic, synergistic, and antagonistic muscles, right? Both concentrically and eccentrically when it generated the pain. So one of the things that we are really interested is when I clinically, what you see, I think a lot too, that they have pain in the Achilles tendon, they walk funny, Sometimes they develop tibialis posterior, peroneal pain, or the arch pain, or people sometimes with plantar fascia have weakness in the calf. Like, what is going on here with the loading? And one of the things that we're doing now, which I think is really interesting, is because we can compare using electrical stimulation. We can stimulate a specific muscle versus plantar flexion torque. We don't really know what muscles are contributing to the plantar flexion torque since there are so many other muscles. And we have techniques too, thanks to Stephanie Cohn that I collaborate with, who's biomedical engineering, is we can do a tendon tapper on the tendon. So basically it taps the tendon, and depending on how fast that wave go through, we can measure the speed of that wave, and the tighter, more tension to the tendon, the faster that wave speed. So that's how we can calculate the tension that's in, or what we call Achilles load, right, with various activities. So basically what you can see, this is like a gait cycle, right? The more before you have push off, you have a tighter in the tendon and the wave speed is higher. And what we've done is looking at this in plantar flexion, comparing voluntary contraction to electrical stimulation. And this is just some of our data to show. And what we see is here, for example, you put somebody down in a humac and they push down in plantar flexion as your max voluntary isometric contraction, and they get a torque output here. And then we put electrical stimulation on the calf and we stimulate. They are not trying to do anything. Now we generate the torque with electrical stimulation. And then we can see the torque output here, the second bar. And then the third and fourth bar is just to show that we can get 20% of the MBIC both voluntarily and with the electrical stimulation. And what's interesting here is that we have 79 Newton meter in torque when they push, and the electrical stimulation is 30 Newton meters. And that can be a lot of reasons, right? Because people, it's uncomfortable electrical stimulation, but we turn up as high as we can. But now this is about 60% lower. But now when we look at the wave speed, that might be related to more of the Achilles tendon tension or the Achilles loading when we're doing it. We see, and the wave speed is direct kind of measure on that. We see when we compare the electrical stimulation versus the active contraction, we see that it's only 19% lower. So somewhere here, there is a discrepancy with what we think how much the torque output is versus maybe how much goes to the Achilles tendon. And I think that's what's going to be really important, because we have a tendency to throw a lot of weight on somebody, while if the weight gets too heavy, they might just compensate more, and we can actually see a negative effect to loading the tendon. So I think that's where you got to be really careful, and especially in clinically, and I know for a lot of new clinicians too, that you have the desire of making the the exercise more Instagram worthy, right? So you have all of these complicated exercises, but if it gets really complicated, you might not actually get the load in the area that you want it, because the body is really, really good to compensating. And this is in healthy individuals, and we are now looking at it, people with Achilles tendinopathy, to kind of understand, are there variables of how MBIC that might actually be better to load, and can explain how these differences in the different individuals. The other thing too that I think is really important, I have a few more slides here too, is to thinking about just giving somebody an exercise. And some of the doctors that I work with when we started talking about eccentric training was, oh, just give them an eccentric drop exercise or eccentric stretch exercise. And my concern then too is when we're talking about, we want to get that strain in the tendon. So you want to have that load slow and controlled to get that strain. Let's see if I can, I don't have too loud here, right? So this is like, you really want to look at how people exercise, going concentrically, and they really need to control the negative phase, right? The eccentric phase, to get that strain in the tendon and control the motion, versus what you can see some of them, if you call it an eccentric drop exercise, that will be something like this, just dropping down. Now you don't get any tension in the tendon. You bypass almost the tendon, and instead you get a jerk at the end range, and people start developing insertional problems, right? So how they do the exercise to get the loading is really going to be important. And we've talked mostly of, mid-substance Achilles tendinopathy, but also insertional is a big problem. So here what you're having, this is an ultrasound images to the right. The blue is the calcaneus. Between the yellow lines are the Achilles tendon. And these images are taken from the person standing here in plantar flexion, neutral, and dorsiflexion. And what you can see here in the neutral, the tendon looks pretty good around coming from the calcaneus. But when they go into dorsiflexion, the tendon actually wraps around the Achilles. And now we're getting a lot of compression. And people with insertional tendinopathy have too much compression and thickening here that causing the pain, right? So for those, you want to be careful with the dorsiflexion and really thinking about what position and how do you control it. And there we see people with insertional, if you control that position, they have better outcomes. So instead of aggravating it, right, you can actually load the tendon to restrain by avoiding that compression. And we've seen in one of our study with a Nabil, another PhD student, that these 2 centimeter heel lifts, if you give 2 centimeter heel lifts and you do the ultrasound, the majority of patients, you can see that the Achilles tendon is actually lift off from the calcaneus and works really well. So we gave these to individuals, right? And people with insertional Achilles tendinopathy had immediate decrease in pain with walking. And after 2 weeks, we actually had significant decrease in pain. We had an 8 out of on the VISA score. So just thinking about if you have somebody with insertional, yes, you don't want to stop loading them, but if you can offload the compression, then you can do exercise and then you might be able to get a lot better moving forward. And the last part here too, I just want to give a little bit so you can thinking about the sports or the return to activity too, right? So you want to load them, you want to progress them. I've said this recovery several times, but what does that mean and how do I handle that? And through my research and also through as a PhD student, one of the most common questions I got from patients was, okay, you tell me I need to do my exercises, the tendon's going to heal, I need to recover, I need to load it, I'm going to do my daily heel rises, I'm going to fill out my training diary, I have my pain monitoring model. You tell me this can take 6 months to a year, but I am not going to stop running, or do I have to stop running or jumping, or do I have to stop hiking like with my activity? So we really try to look at the literature and there's really nothing out there. So we actually did a study that was published in 2007 comparing allowing people to continue with running and jumping using the pain monitoring model versus not being allowed to do any running and jumping. So basically people had to follow the pain monitoring model. As long as the pain level was not above a 5, you were allowed to do it, but the pain had to come back down to your stable level before you were allowed to do any running and jumping again. And we tried to have 2 to 3 recovery days between those kind of activities. So for a lot of people, instead of running, 10 miles, they can run 2 miles, right? But they were able to run and kind of load the tissue. And when we compared, for here, it might be a little hard to see, but the one line is for what we call active rest, and the other one we called exercise. So the active rest group was actually, they're allowed to do the rehab exercises, but no running and jumping. They were allowed to walk their dogs. We like dog, but they couldn't walk like for speed walking or for long distances. And the other group was allowed to. And it might be a little hard to see, but at 6 weeks, the exercise group probably had a little bit maybe lower VISA score relating to pain, but these were no significant difference. And then as we progressed 3 months, 6 months, 12 months, there's no difference in their outcome. And both the groups recovered really, really well. The active rest group was allowed to also start running and jumping with the pain monitoring model after those 6 weeks. But I think to me, and we looked at hopping pain, this is the pain that we also look at really good to evaluate pain, right? Not just as asking a numerical pain rating scale, but actually pain with loading. We have them stand on one leg and jump, just like you saw in the beginning of the video, and rate the pain level. And this pain level decreases same over time in both groups. So I think it's clear to show that using the pain monitoring model and modifying the load control and really have recovery days is something we can do during the rehabilitation. So I think it's important as a clinician to think about it's not like I'm going to do rehab here and then we're going to start running here and then in the next step. Like we can start working on these together, and the pain monitoring model works really well for that. So we have built on that with daily rehabilitation exercises would be 2 to 3 recovery days between heavier load activity. And we published this. If you're interested, you could reach out to me too in 2015 in JOSPT to describe our return to sports model. But we use basically pain monitoring model. Recovery days for the tendon has been shown to take maybe 3 days from heavy loads. So things that they are considered that have more pain, more in the acceptable zone, but they also can use the Borg scale to rate is a high load on their tendon, then we really want to have 3 recovery days. But for some individuals, maybe walking every day can be a light load you can do every day, but then running 3 miles at higher speeds, then you need 3 recovery days, but still doing the rehab. And this works very well, and it's worked very well through my career. And I'm working with professional athletes, professional runners, and people have used this kind of pain monitoring model and pain progression in other muscle injuries, hamstring tendon injuries, and those kind of things as well. So in summary, like looking at this to thinking about Achilles tendinopathy, I think there are a few things that you have to have with you, right? Tendon needs loading to recover and heal. You just need to modify, but having no loading is not necessarily beneficial, but too much might be overloading it too. So this is where the balance really comes in. Type of muscle contraction does not seem to matter, but progressive loading with dosing using the pain monitoring model is really effective. And we now have more studies showing how to progress also with the tendon load to understand how various activities load the tendon. And pain and tendon structural changes alters muscle recruitment and subsequently tendon loading. So just because we say you're going to load the tendon, you really want to make sure that you actually sometimes maybe the lower load is better than thinking you're doing a higher load, but they're compensating more. NMES is one thing that we really used for a lot for the knee and the quad, but also might be a really good way for early on with people with Achilles tendinopathy to make sure they load the Achilles tendon if they have difficulty for the recruitment and not having good neuromuscular control. And biomechanical variables may matter for the individual athlete. We didn't have time to talk about it a lot, but people asking about shoes and foot structure and those kind of things too. In general, broadly, we don't see that to be a very big difference and no clear indication. Doesn't mean it couldn't be a problem for your individual person in front of you. And then sometimes we see adjunct treatments might be beneficial in the short term for our patients too. So that's a whole other lecture, right? But again, regardless of orthobiologics, shockwave, laser, all of those things, exercise is key with it. And I want to end with do I have time for that, Ben? You can nod.
We've got a few good questions in there that I know they're excited to hear. So up to you.
Okay, so I'm going to skip on this one. I want to go to the questions instead and thank everyone. We can leave that on.
Absolutely fantastic presentation. Thank you. And all of your, not only experience, but all of your research. It's amazing to see how much you've contributed to the field. So with no further ado, let's jump into these questions. So first question is, given the strong evidence for progressive loading programs, where do you currently see ultrasound guided procedures like tendon fenestration fitting into the treatment plan?
Yeah, so there are a lot of various kind of adjuncts, what I was getting at, right, too. So I think we really need to look at the evidence. I do not like when people put needles into the tendon in the rehabilitation area, too, because that's where we've seen problems, right? Shockwave has really good evidence for it. We see some good evidence. People have maybe used laser and shockwave for those kind of things, too. I would keep any of those invasive things to the last thing that we're kind of seeing, because I have seen a lot of negative effects from that too. That would be the case for the person that is not getting anywhere, that they consider maybe surgery, and there's a lot of various methods to do it. It used to be that they were cutting the blood flow to the area or scraping from the peritoneum and all those kind of things too. But I think at this point, there are a lot of other pathways except to having to mess with the tendon too much, and those should be saved for the last stitched effort.
Great. And next question. Thank you for all the insight. Number one, how many heel raises do you prescribe to patients in the different profiles? And is it daily to load the tendon? And the second question, how long do the insertional tendinopathy patients keep the 2 centimeter heel lift? And do you have them wearing both shoes to avoid functional leg length discrepancy?
Yeah. Amazing question. So, with the first one, so for the protocol, and I'm happy to share too, we tend to start like the typical PTs, right? I wanted people to get up to 3 sets of 10, 3 sets of 15 with control. So, we start with bilateral heel rises, 3 sets of 15. We want to build up to single heel rises up to 3 sets of 10, 3 sets of 15. And following that, it's easy for the different people, right? Because regardless of which group it is, you kind of fit. So, some people are in some of the activity dominant, they might be able to do it really easily. So then we can progress to load early on, right? But we've seen daily exercise, I feel like it's a really good medication. And I've been sticking to at least some kind of daily exercise. For some people, that means heavy 3 times a week. They go to the gym and then they do the lighter, but some kind of exercises at home, right? So we kind of work with that a little bit. We're thinking about it as we want to get this all overload during the week, and we can disperse that a little bit differently depending on if they have weights or no weights too. But some kind of input to the tendon daily seems to be working really, really well. For the heel lifts, we use the heel lift, the 2 centimeter heel lifts, to get the pain under control. We don't want to use those forever, right? But that's if they have too much pain with their walking, we can't even get the exercises going or loading the tendon. So it depends a little bit how their pain level is. We want to try to get those down at least after about 3 weeks, and it should be a temporary solution. It's not the end all solution, right? But a lot of them do better in shoes that at least have a little bit more of a heel drop. And what was the last part of that question? There was something.
Yeah, that was it. Just to avoid the functional leg length discrepancy, do you put it in both shoes?
Yes, in both shoes. Yes, I don't want them to be walking and limping. Thank you.
Fantastic. Another question. Thanks for the great presentation. Is there better timing to perform exercise for tendinopathy, morning versus evening, or any other insights on that?
I mean, I think that's a great question. So the question is, should I do in the morning, in the evening? The other is, if I'm going to running and jumping, should I do the exercises before and after? For elite athletes, which day should it be in the season, like, or during the week, and kind of fitting it in? And I think a little bit is in trial and error. A morning versus evening, it seems to be split amongst my patients. Some feels really good. I think the key is it's better you do it, find a routine that you do it, right? So some people feel like when I get up in the morning, if I do it, I have less pain and I'm moving a lot better, right? Some people feel like at the end of the day, I'm too painful, I can't do it then. Or some people feel like this is the time for me to get the exercise. I don't think there is any evidence to say one or the other. There are some people actually looking at the circadian rhythm and tendon and things too. So that might come in a different, but for right now, we don't have any evidence for that. Performing it before and after activity too is a lot of times we're performing the daily exercises as the warm up, the heel rises and things too. It's almost like that, or isometrics is like the pain relief before you maybe do sports and running. But if you want to do the heavier loading, you don't always want to do that beforehand, right? So that might be more afterwards. And usually when people, the professional teams, you're thinking they're going to play on Saturday, right? It's usually after played on Saturday, Sunday, Monday is the recovery. Tuesday, Wednesday is the opportunity to build the heavier and build it up. And then they're starting to taper off Thursday and Friday again. So those are kind of how people are building the exercises. But it's again with the pain, the training diary and the pain monitoring model, you can really work on that, fitting that into each individual patients you have in front of you.
All right, we will take one final question because I know it is late on a Tuesday, and we are so thankful for everyone's time here. Are you familiar with Keith Barr's work regarding stress shielding and required time under tension to get the load to transfer to the diseased tendon fibers?
Oh yeah, absolutely. And Keith and I have lectured several times together too about those kind of things too. So I think that there's a few discrepancy with how Keith and I are interpreting the evidence and how what we are the recommendation. I think together we are both saying you need to load the tendon. The tendon needs to be strained to kind of getting the recovery. His research comes more thinking about from the animal models and looking at patella tendon. I'm looking more at the Achilles tendon, and I think that are some of the discrepancies too. Like, do you have to strain it so much you actually load that area? the Achilles tendon is twisted too, right? We haven't even talked about that, but it's actually three subtendons that twist as well. So I don't think you necessarily have to do isometric to make sure that you're loading the area that you get because of the anatomy, right? But I think the point is that you need to load enough so you get strain on the tendon and getting load on the tendon, right? So if that is isometric, if that is isotonic or those kind of things, I really don't think that matters. I think it's making sure that you're actually getting the load and then finding it for that individual is going to be the key.
Karin, incredible work. Thank you so much for all of your contributions and for volunteering your time on a Tuesday night. We are all grateful to have an expert of your caliber contributing to this. So thank you again. Thank you all who are attending and who are watching the recording now. Please stay tuned for our next Residency Hot Topics on April 7th related to neural tension in throwers. We have some incredible presenters from Memorial Hermann in Texas. So looking forward to that as well. Karin, thank you again and good night to everyone on the call.
Thank you so much.